Hello, George. How are you? It's Tuesday afternoon.
Hello, Dr. Bravissimo. Welcome. Today's our second year anniversary of the podcast,
S-
and we have a wonderful guest, Dr. Luigi Meneghini.
There you go.
I got the Italian going.
The Italian going there.
The topic of discussion is going to be type 1 diabetes is an autoimmune condition progressing to a metabolic disease requiring lifelong insulin replacement. Very doctor-like.
So
Yes.
before we get on introducing our guest, I invited Dr. Luigi. Luigi is a good friend of mine to celebrate the first episode of our third year on the podcast. As all of you, I love Miami. And so this is one more of my friends in Miami. And George missed out on a great dinner and a great time. We didn't attend to see him either this year, but we'll forgive him.
It was raining.
Luigi
Well,
has
it's not raining in Miami, that's for
That
sure.
day it was raining. I was supposed to come down to Pompano Beach, but it was pouring.
Oh, I missed
Luigi
it.
has a phenomenal life story. He is of Italian descent, then lived in Africa, then moved to the US, then became a physician in the US. And his life passion is to cure diabetes because his sister was afflicted with the disease or is afflicted with the disease. His passion is taking him through many roads, and an incredible genius as he is, he has led the program at University of Miami and Jackson Memorial Hospital on diabetes, at UT Texas, and now he's working at Sanofi as the global external expert lead for autoimmune type 1 diabetes. Luigi, my dear friend, welcome to the podcast. It's a joy to see you again.
Thank you. That was a great introduction. I think I'm glad it's recorded because my 95-year-old mother, who still is surviving in Italy, not in a blue zone, but is going to love to hear that introduction.
So Luigi, I think of you as a pediatrician. Why weren't you a pediatrician and a pediatric endocrinologist taking your type 1 diabetes?
That's a great question, Irvin. And yes, you gave my life history in 3 sentences. I was born in Italy, in Chiavari, Liguria. That's where pesto comes from, and focaccia, and a lot of other things that are delectable to eat. Grew up in Liberia, in West Africa, and at a very young age knew I was going into medicine, right? And actually, the arm of medicine that I was most attracted to was pediatrics. I just loved the interactions with the children. They were always sunny. They were engaging. They didn't have a lot of the baggage that adults did. And when we moved to the States, I was 16. I was going to start my last year of high school in the States. My sister got diagnosed with type 1 diabetes. And I have to tell you that my sister is needle phobic. And by needle phobic, in Africa, you used to have to get all these immunizations, and they required a needle. If she went before any of the other brothers, nobody else wanted to go in. She would scream her head off. And the fact that she got a disease that requires her to this day to inject several times a day is just, it's ironic. I went through medical school in the States at Emory. And when I was done with medical school, I needed to decide what to specialize in. And at that point, my sister was no longer a kid. She was at that point a 21-year-old with type 1 diabetes. And I really wanted to do something that would benefit her in her lifetime. And therefore, I thought possibly going into the adult arm of medicine as opposed to the pediatric arm would better align with what her needs were. And so I did internal medicine and then went down at the University of Miami, did my fellowship in endocrinology and diabetes. And at the end of that, stayed on at the Diabetes Research Institute. And the reason there was they were cure focused. They still are cure focused. They're trying to find the cure. And I figure, let me be at the place where if something really remarkable happens, I'm there to translate it for my sister and for a lot of other individuals like her. And so I did 20 years at the University of Miami on faculty there. And as you pointed out, I then spent between 2014 and 2020 at UT Southwestern within the Parkland Health and Hospital System. Actually, last week went back to celebrate the 10-year anniversary of the Parkland Global Diabetes Program that I went there to start. And that was an amazing experience. I've been blessed in so many ways, but yes, I did not become a pediatrician. I became an internist and then an adult endocrinologist.
Just for our audience who may not be familiar with University of Miami and Jackson Memorial, just on the adult endocrinology section, it is so humongous. There's endocrinologist and then there's diabetologist, right?
There's one specialty, which is endocrinology, diabetes, and metabolism. But you're absolutely right, Herb, that in many cases, there are individuals like me, I'm an endocrinologist, that focus on diabetes. I had a special reason to focus on diabetes. I had a personal reason to focus on diabetes. But there's a lot of endocrinologists that actually maybe do diabetes on the side and focus on other aspects of endocrinology, like thyroid disease, adrenal disease, pituitary disease, bone disease. In pediatrics, you obviously also focus on a lot of growth issues and other factors. So absolutely right. There are those that specialize in diabetes primarily with some endocrine practice. There's those that focus on endocrine practice with some diabetes.
And then UT Parkland Memorial, there's a UT Southwest and Parkland Memorial's hospital.
Yes.
That is an incredibly huge beast. In pediatrics, I can't remember, but I'm going to say they have a cardiac pediatric ICU with something like 20 beds just for heart surgery. That's not their general PICU. That is a monster of an institution, and you were there leading their global diabetes program.
I was at UT Southwestern Parkland Health and Hospital System, and you're right. There is a humongous pediatric presence there. There's also a Texas Children's Hospital that is right there. That is one of the leading institutions in the county, and so there's a lot of activities and a lot of collaboration that goes on between the adult entity. Parkland has a pediatric footprint, but it's a outpatient pediatric footprint, and collaborates very closely with Texas Children, for example, to help care for children if they need to be admitted to the hospital. And so there's a lot of activity. And as you can well imagine, Parkland Health and Hospital System is serving Dallas County. And so they see everybody that walks through that door. And it's an amazing place and with amazing collaborations.
I want to touch a little bit on what is autoimmune type 1 diabetes as we know today versus when I graduated from medical school in 80.
What is, sorry, Herb, I didn't hear, what is?
Type 1 autoimmune diabetes as
Yeah,
opposed to what it was
yeah.
when I was in medical
Yeah.
school in 89.
So the way that we talk about diabetes or describe diabetes has changed very much, right? When you and I went through medical school, it was known as, type 1 was known as juvenile diabetes because a lot of kids would get type 1 diabetes and not many, if any, would get type 2 diabetes at the time. Type 2 diabetes, on the other hand, was known as adult-onset diabetes because the majority of individuals getting it were in their 40s, 50s, and 60s. And while that is still somewhat true today, we know that type 1 diabetes affects both children and adults. And type 1 diabetes is a very distinct disease. You mentioned the autoimmunity. So the autoimmunity is actually the immune system for some reason, and we're still trying to figure that out, that one day decides that some of the proteins, the molecules, the antigens on the surface of the insulin-producing cell, on the surface of the beta cell, look foreign and starts an immune attack on those beta cells. And that immune attack continues in many cases until there is insufficient insulin production. And these children or adults will present often in severe hyperglycemia and many times in diabetic ketoacidosis, and will require lifelong insulin therapy for survival. Type 2 diabetes, I'll stop there because you look like you had a question.
Yeah. In 89, when I graduated from medical school, I can only diagnose a child. And in my mind, we used to call it insulin dependent diabetes.
Mhm.
And I could only diagnose you when your glucose was like 300 and you were peeing like a racehorse.
Mhm.
There was no other way of diagnosing you. And it was a life sentence. From there on, you're going to have to count every carbohydrate you take. You're going to have to poke your finger before you eat, poke your finger after you eat, give your cells shots. It was what called NPH back then, in the morning and at night, and then regular to correct
Mhm.
or your eating habits. If you're a student athlete and you are going to go run or play a soccer match, then we had to adjust your carbs and your insulin so you wouldn't become hypoglycemic while you were on the pitch. Incredibly complicated, burdensome, not only for the child, but for the family. Now, through your education and that at your team, I now know I can diagnose this disease years before that event happens through measuring autoantibody. So, how has that changed the way we think about diabetes?
Those are great points and great questions. And just to absolutely touch on the burden of self-managing diabetes, especially type 1 diabetes, that requires a level of attention and complexity that is just mind-boggling. It's tremendous. But let's go back to your question about the diagnosis, because that is a clear point. Because when we talk about type 1 diabetes means hyperglycemia, high blood sugars. We usually think of the individual, whether a child or an adult, that presents with severe elevation in blood sugars or DKA that requires insulin therapy. And along with the severe elevations in blood sugars, they're thirsty, they are hungry, they're losing weight, they're getting up at night to pee, their vision is blurring, and they're having all of the symptoms of hype. And that is the metabolic complication of a process, an autoimmune process that appears to start very early on in life. And what you were pointing out, Herb, which is so interesting, is that we can actually detect that there is an autoimmune process, an autoimmune destruction of beta cells that is going on months to years before a diagnosis or before an individual presents with elevated blood sugars because of type 1 diabetes. And this is mind-boggling because this is information that has come out over the last, I would say, 10 to 15 years from these very large screening programs going on in the United States, in Europe, where they've determined by following children from birth that those that will go on to develop type 1 diabetes when they're, let's say, 6 years of age, 10 years of age, 15 years of age, 20 years of age, actually develop the antibodies against the islet cells, against the pancreatic islet cells, most of them by 5 years of age. And actually, those antibodies start being present around 9 months of age and peak around 2 years of age. So very early on in the life of somebody who's going to develop type 1 diabetes later on, we can already detect antibodies to type 1 diabetes. And that's a diagnosis, right? Now we have a way of saying, yes, if you have autoantibodies, there's 2 or more of them, and you can repeatedly show that they're there. We call that stage 1 type 1 diabetes. And that's just the antibodies. Your blood sugars are completely normal. On the other hand, if
I'm going to stop there for a sec.
yes,
So there's 4 autoantibodies that you can measure that destroy the beta cells in the pancreas. What are those 4 antibodies?
Yeah. So the antibodies, we don't know what the role of antibodies are in the disease process. We don't know whether they are responsible for the damage. We definitely know that there are these white blood cells called T cells that are attacking the beta cells and destroying them. When you have an immune response, an immune reaction, your B cells, different from the beta cells, B cells are also white blood cells, will produce autoantibodies that usually are meant to augment the immune attack or the immune rejection, usually bacteria or viruses or what have you. And these autoantibodies we can measure. And there's 4 of them, as you pointed out, that we tend to measure to make a diagnosis of autoimmune type 1 diabetes. And there's something called GAD, glutamic acid decarboxylase, IA2, insulin autoantibody, and a zinc transporter called ZNT8. And these are the ones that we usually check to understand if somebody has an autoimmune condition going on. And if we find 1 or more positive antibodies, then we tend to want to recheck to ensure that is what we are seeing.
The Italians are way ahead of us on this, right? They're testing everybody, population-wide testing. But from the data that I've seen, the peak in autoantibodies in pediatrics occurs at 2 years of age. There. And the peak incidence of insulin requirement in pediatrics, which is less than half T1D, occurs about 10 to 14 years of age. So without being a scientist, I'm thinking this autoimmune process is very slow. It starts at 2 and it takes 8 to 12 years to totally destroy your pancreas. Is that about right?
Yes and no. And what you identify, Herb, is one of the key aspects of type 1 diabetes that we need to understand better. Why? In some kids, they develop the antibodies and within 2-3 years, they have high blood sugars and clinical type 1 diabetes, whereas others might take 10 years, 15 years to actually get to type 1 diabetes. And we know certain things about them. We know that certain antibodies, if they're present, are more likely to identify somebody that's going to get to clinical diabetes faster, like that IA2, one of the 4 that we've identified. We know that if you have multiple antibodies present, 3, 4 autoantibodies present, you're more likely to progress faster than if you just have 2 autoantibodies present. And there's other characteristics in there. Also, the amount of antibody that's present is also telling in terms of how fast you may develop clinical type 1 diabetes. But absolutely, that there's still a wide variation. What we know is that if you have 2 autoantibodies that are repeatedly positive, and we follow you over your lifetime risk of developing clinical type 1 diabetes, so now called stage 3 type 1 diabetes, approaches 100%. And that's clear. And that comes, again, from these large studies that have followed children from the very early life stages.
And then in 1989, you were either insulin-dependent diabetic or non-insulin-dependent diabetic, and there was gestational diabetes, which has always been around. But now type 1 diabetes or autoimmune diabetes is stage. And we go through 3 phases.
Yeah.
So what are those 3 phases for T1D?
Yeah. No, that is great. And the stages were identified back in 2015 in the ADA, the American Diabetes Association Standards of Care. And they were identified to better characterize these individuals that were identified as having autoimmunity so that research could be conducted in terms of seeing how they progressed and seeing what type of interventions could possibly delay the onset of clinical type 1 diabetes. So the first thing to do, as you pointed out, is identify that you have autoimmunity. So diagnose the autoimmunity with the autoantibodies. And so you test the autoantibodies. If they're positive, 2 or more are positive, you repeat the test. They're still positive. You know you have autoimmunity to type 1 diabetes. The next step that you do is you do a metabolic assessment. You try and understand what is their glycemic status. And there you can do a variety of things. The gold standard that's been used in these programs has been an oral glucose tolerance test. And I think you know what an oral glucose tolerance test, but we can talk about it later if you want. You could also do a fasting plasma glucose, right? That there's a diagnostic criteria for fasting plasma glucose that is either normal or within that, I'm going to call it pre-diabetes range versus the diabetes range, or you can do an A1C, right? There's the normal A1C, the pre-diabetic type of A1C, and then the clearly the A1C that's in the diabetes range. And so you do a metabolic assessment, and if your metabolic values are completely normal, then that is stage 1. You have autoimmunity, but normal blood sugars. If your glucose levels, these tests show that you have, I'm going to call it prediabetes for your audience, because that's a term that I've always been familiar with. They're calling it in type 1 diabetes dysglycemia, abnormal glucose level. But dysglycemia is basically a range of glucose values that's in the prediabetes range, right? A fasting plasma glucose that may be between 100 and 125, an A1C between 5.7 and 6.4, right? And an oral glucose tolerance test between 140 and 199 at 2 hours. So if you identify dysglycemia, this pre-diabetic state in somebody with autoimmunity, that's called stage 2. The importance is that at stage 2, if I follow these individuals for 4 years, 3/4 of them will develop clinical type 1 diabetes by that point. And clinical type 1 diabetes, meaning with the hyperglycemia, that is what we call now stage 3 type 1 diabetes.
But once you're on stage 2, 75% will end up being insulin dependent within 4 years.
Yep, that's the statistic that's been worked out.
Wow. Now, people often ask me, why test if there's no? So why know that you have the antibodies when it can't be cured?
Yep. And you're absolutely right. Type 1 diabetes cannot be cured right now. And there's a lot of research, a lot of efforts to try and understand what is the path eventually to that prevention and cure for those that have it. A lot of effort being spent there. But there are a lot of advantages to knowing that you are an individual that's at risk of developing hyperglycemia. One of the biggest benefits in this country, the number of kids that are diagnosed with type 1 diabetes, 40 to 60% of them will present with diabetic ketoacidosis. Diabetic ketoacidosis is a severe condition where there's so little insulin in your system that your body starts breaking down fat, starts breaking down muscle. All of that goes into the liver. And because there's no insulin in the liver to use that fat and muscle, get converted into ketones. Ketones are acidic. And once they accumulate to a certain level, they turn your blood acidic. Therefore, the diabetic, high blood sugars, keto, high level of ketones, acidosis. And that is a condition that if it's not treated emergently, will kill you. And it's a condition, and there is mortality associated with diabetic ketoacidosis. And it's also a condition that can be associated with more difficult control of your diabetes in the years that follow that diagnosis. A1C levels tend to be higher in people who are diagnosed with DKA versus diagnosed before DKA. There can be some cognitive impairment associated presentation of diabetic ketoacidosis versus not. Why am I saying all this? Because if you look at these screening programs that have been in place, they're able to reduce that risk of presentation of a child in DKA from about 40 to 60% to under 5 to 10%, which means you've just lowered your chance of a kid presenting with an acute condition that has lifelong implications by substantial.
I have a comment on that. Back in the day when Herb and I were little interns, we used to see lots and lots of DKA. Many nights were spent adjusting the insulin and correcting all the electrolyte imbalances and so forth. Now that I've been practicing in private practice for, oh God, too many years, I don't recall seeing patients come in DKA anymore, but they do come in with diabetes. So they'll come in either they're urinating a lot, the classics, or they come in and they're not feeling good. It was dramatic weight loss, or somebody does a glucose. Very common is the grandmother has diabetes. The mother was curious and takes a blood sugar.
Mhm.
But that's with access to care, I think.
Yeah.
So when you have access to care, you're probably not going to have a DKA condition. When you don't have access to care and you only access the emergency room, you probably have DKA. What are your thoughts on that?
Yeah, no, that's a great point because you're absolutely right that the children or even adults that are more likely to present with DKA are those that have challenges with access, that don't have insurance coverage. And that's a challenge to access, that come from lower socioeconomic backgrounds, or there are even some racial, ethnic backgrounds that also make it more likely for you to present with diabetic ketoacidosis. And yes, that range is quite wide. The other interesting thing is that if you have type 1 diabetes in your family, then you're less likely actually as a kid to present with DKA than if you don't have any type 1 diabetes in the family. Because you have parents that have one child who has type 1 diabetes and they're more alert to potentially the early signs and symptoms of hyperglycemia. That said, we're talking about screening for autoantibodies. We haven't talked about who we should screen, but clearly family members might be a good target, and we can talk about that. But that only represents 10% of people that are going to present with type 1 diabetes. 90% of people who present with type 1 diabetes have no family history of type 1 diabetes. And those are the ones that are at even higher risk of presenting with an acute condition like DKA.
The data is very clear, right? A lot of this data comes from Barbara Davis in Denver. Non-white children on Medicaid, younger children, are at the highest risk to present in DK. And even when you do have diabetes, we had one patient in the clinic recently, they're 20 months old, got a cold and presented with DK. The father has insulin type 1 diabetes. And we heard the story of Dan Fighton, who's a very well-known pediatrician. And he has 3 adult sons with diabetes, type 1. The youngest one presented at 2 years of age, was the third son to get diabetes. And he came home from clinic on a Saturday and found him basically in DKA. So being young is a really high risk because it's so much more difficult to see the symptoms, even if you're a trained pediatrician with 2 children that have diabetes. You alluded to the harm. There's harm presenting in DKA. The first harm, obviously, has about 1% mortality related to cerebral edema. And that's if you're in a country like the US where there's access to pediatric intensive care units and pediatric endocrinologists, and they're very measured. They rehydrate you, they give you insulin, but they don't change your metabolic makeup too fast so there's not a fluid shift and you herniate. And that's what gives the pediatric interns stomach ulcers, because that could be any minute and the child's gone. However, there's also long-term data that shows that if you present in DKA, you have a lower IQ, EQ, and some other developmental delays. And Barbara Davis reviewed their research over 15 years, and those kids that do present in DKA, they broke it out with moderate or severe DKA, have significant higher levels of hemoglobin A1Cs for the next 15 years. And we might say, what's the difference between a hemoglobin A1C of 6.5 versus one of 8.5? The research on retinopathy of diabetes, diabetic retinopathy, is that if you lower some like minimal, like 4%, 5% decrease on your A1C, you decrease the burden of the eye disease by 10 to 20%. So having a hemoglobin A1C through your lifetime as a child, averaging around the nines because you presented with DKA, means that your eyes are suffering. And if we could just prevent that event, we might just that one thing spare your eyesight. We're not even talking about your kidneys, your heart, all the other microvasculature that gets affected by the hyperglycemia.
That diabetes is going to be type 1 diabetes is a challenging disease, whether you present with DKA or not. It's a lifelong struggle. It's a monkey on your back. It is, you speak to kids or parents or adults with type 1 diabetes, and it is mind boggling what they have to do just to get blood sugars to a level that's not going to harm them. So if they do everything right, you know what happens? Nothing, which is the good thing. And what you're pointing out is the fact that when they present in DKA, there's an even larger burden to carry over that period of time, which is absolutely right. But I wanted to come back to your initial question and started this discussion on DKA about what is the advantage of screening. We talked about DKA extensively, but there's a few other advantages. Another advantage that might go underestimated is the fact that if I know that I'm in stage 1 or stage 2, I can get prepared for an eventual diagnosis of stage 3 of clinical diabetes. I can get information about what it is. How do I manage it? What are nutrition aspects of it? How do I manage my lifestyle? And I can get ready so that when that diagnosis happens, A, it's a softer landing, but B, I'm also ready for it. And that is a huge opportunity. And I before we end this broadcast, I also want to talk about some of the potential psychological burden of knowing
That's psychological.
Yeah, we'll get to that. Let me just get to the third point. Third point is, if you know that you're in stage 1 or stage 2, there's obviously some options that you have, either with joining clinical research programs or treatment that you could go down the road, and we won't touch that any further. But let's get back to you wanted
And
to
then
psychological.
one more observation before you go into
Yeah.
the psychology. I do think there's some, if not research, some belief in the community that if you are at stage 1 and you watch your metabolic health, you can do better than if you don't know that. So good diet, good exercise, the things are what we're supposed to be doing, but any little thing to delay that insulin dependency is huge to the patient.
Yeah, so you bring up a good pointer because there are a couple studies. There's not too much information on this, but there's a couple studies that show that changing diet and lifestyle doesn't change the autoimmunity. It doesn't decrease or increase the risk of autoimmunity, but it does delay, as you point out, the time to needing insulin. And so that's another tool that you certainly have to deploy if you're in stage 1 or stage 2.
So let's talk about the psychological burden, both for, I'm going to say the mother, might be a little bit emotional.
Yeah,
The
awesome.
mother is the one that carries that burden, but also for the clinician. So what is the burden, psychological burden for the parents of these children?
That I'm going to put it in perspective, because one thing that we haven't talked about is the risk of being autoantibody positive, right? If I'm getting screened, then let's say I get screened. I have a sister that has type 1 diabetes. Actually, her son also has type 1 diabetes. So that was quite unfortunate. But my risk of having type 1 diabetes should be my lifetime risk around 5%. And if I get screened for autoantibodies, probably my risk of having autoantibody positivity is around 3 to 5%, 3 to 5 out of 100. Not a huge risk, but a substantial risk. If, on the other hand, I had nobody in my family with type 1 diabetes, that risk would fall about tenfold. So it'd be about 0.3 to 0.5% risk of being autoantibody positive. I'm saying that because the majority of people that get screened will be negative, right? Will have negative autoantibodies. And if you're a child, it depends what ages you're getting screened and whether you need to get rescreened or not. If you're an adult and you get screened and you're negative, I think you're pretty much done with regards to worrying about type 1 diabetes. If you screen positive, and let's assume 2 or more persistently positive autoantibodies, so you have stage 1, or if you have prediabetes, range dysglycemia stage 2, then that is definitely something that causes a lot of anxiety, concern, and burden for parents. And as you pointed out, mothers bear more of the burden than fathers. And so, yes, there is that component. And it's important, if you're having a screening activity or program, to have in place people that can talk to the parents and can and the child or the adult who's at risk, and walk him through what this means, how to prepare, and all of that. That burden, that anxiety, mental health burden, will decrease over time, so that by the time these families get to a diagnosis, their experience is a lot less burdensome, anxiety producing, and mentally taxing than somebody who just presents out of the blue. So there's certainly an issue that we need to address when we identify somebody that's autoantibody positive, that needs to be carefully curated and managed. But there is the advantage that when the diagnosis does happen, that those are children and families that are much better prepared mentally and in terms of their knowledge base to manage type 1 diabetes.
Definitely. And so please remind me, I want to touch back on something because as physicians, we tend to be very pessimistic, and there's some fears that are and biases that are embedded in us because of our life experience. I feel like diagnosing a child with T1D is just a horrible thing, just a horrible thing. But I want to talk about that in a minute. From the clinician point of view, as a pediatrician, as a general pediatrician, I no longer manage type 1 diabetic patients because they're too few. And so I wouldn't do as good of a job as you would, or the group in Nicholas Children's would, where they're seeing type 1 diabetics every day. They're using continuous glucose monitoring. They've got study protocols. They got diabetic educators, diabetic nutritionists, psychologists that just talk to the moms and dads and the children. These beautiful things have been around America for 30 years. Diabetic camp in the summer, where all the children go together, they play, they learn, they find peers like themselves. But for me, it's an overwhelming loss and something that I don't have the clinical experience to manage. So I feel that if I test the patient and I walk into the exam room and say, Luigi, your son's best tested twice now for autoantibodies. I know that within 5 years, there's a 45% chance he's going to have to need insulin. And I won't be managing that disease. And I don't have a cure. And that, because we're human beings, create anxiety. And when you get anxiety, you want to shy away from doing it. And so what I want to urge my colleagues that are listening today to do is put aside that feeling, that empathy. This is not a death sentence. We know that at the first stage, we can monitor just like we would do somebody with hyperlipidemia. Draw the A1C every 3 months, educate the parents for signs and symptoms of type 1 diabetes and DKA. Ask them to call us if the kid's sick and they're concerned, so we can bring them in the office, do a quick glucose and test their urine for ketones. These aren't rocket science interventions. I've been doing this for 30 years of my life. And when the day comes that we have to transition to a diabetologist, not only can I offer you somebody in my local town that is a good doctor, but I am blessed. I can tell my parents, I know Luigi. He's a world famous researcher. If you're in trouble, I will call him. I know the researchers at Barbara Davis. They haven't asked. They will not only talk to me, but they will talk to you, independent of me. I know Andrea, another Colombian pediatric endocrinologist in Miami Nicholas Children's, that is passionate about this. If it isn't working, we'll fly to Miami. We'll get her to see you. I'm not leaving you. And as hard as this journey is going to be for us, I know that Luigi's sister's well. I know that he has a nephew that's well. I know that I have a patient that I diagnosed when he was maybe 10 at the urgent care. He graduated from high school this year. He's going to college on a scholarship to play golf. He has a full life. I know that Dan's children, all three of them, are adults living their best lives without complications of diabetes. And I know that science keeps improving to where you don't have to poke your finger 6 times a day and give yourself shots. We have continuous monitoring going on, and we have pumps to put the insulin in you. I really feel that people like Luigi and Andy and Kimber and Copper really getting very close to a cure. So we're not alone. This is not a death sentence. There is hope, and things are going to get better. And I think if you approach it that way, you can do a tremendous amount of good and get over my bias, my fear, my sadness. I can't cure this patient. I'm not a failure. I just can't cure them. But I can stand next to them through this journey and make it a little better. And I think as pediatricians, we need to get over that hurdle and start testing.
It's beautifully said, Irv, and you're absolutely right. I look at my sister. She got it at 15 years of age. She just turned 60. She has no complications from type 1 diabetes because she's done what she needed to do, and she's received the support and the advice from physicians like yourself that have taken her through. And so absolutely right. And I think the message that you're giving, that if you have a diagnosis of type 1 diabetes, you can live a full life, is such an important message to give. Because I can't tell you how many people I've encountered that told me I was an athlete. Not too many people would remember Gary Hall, but he was a multi-medal swimmer in Olympics. Tremendous U.S. swimmer. And after he got done with his swimming career, he moved down to Miami. I had the fortune of getting to know him. He told me when I was first diagnosed with diabetes, between my first and my second Olympic, my physician told me to give up my sports career. You know what he did? Fired that physician and went to find somebody that got into the second and the third Olympics, where he continued to win gold and silver medals. And I just say that story, it's inspirational, but it just tells you that, yes, there is technology that can get you to where you need to be. There are dedicated physicians and people and educators, diabetes educators, so important to have on board that can help you through this journey, and you're not alone in it.
You think back to the days when, I don't know if you remember when you were a kid, Herb, if anybody had asthma, those kids, what happened with them? If they got an asthma attack, they were not allowed to run around. They weren't allowed to play sports. If they got sick, they went to the emergency room for an epinephrine shot, maybe theophylline. And then I experienced this when I came out into private practice, and I told somebody that I think your child has asthma. A lot of people think back to their brothers and sisters when they had asthma and how bad it was. We had inhalers now. We had nebulizers now. You can easily get them. You gave them steroids. You had the inhaled controller meds, the singulars, and all these other meds that came out. And the kids with asthma run around and still play sports. They had to live a full life.
Yeah. Luigi, part of my misconception was that type 1 diabetes was a pediatric disease. How is that not right?
That's a great question, because if you look at the peak incidence of getting type 1 diabetes, it still occurs when you're between 10 to 14 years of age, right? However, the majority of people that are going to be diagnosed with type 1 diabetes are adults or over the age of 18 or 20. And it's about 60% of people diagnosed with type 1 diabetes are over the age of 20 because A, there's a lot more adults than there are children. And B, type 1 diabetes will manifest itself not only in childhood, but will manifest itself throughout the lifetime. And you'll find 60, 70 year olds that present with a new diagnosis of type 1 diabetes. Now, in adults, many of them that present with type 1 diabetes may present with a form that's a slow form of type 1 diabetes than in children. And the younger child you are, the more aggressive the loss of insulin producing cells and the need for insulin might be. But you're absolutely right. And that's why, yes, we need to screen our children for the risk of autoimmunity. But let's not forget that adults that haven't been screened out there could also be at risk and would have the advantage of knowing that.
So currently, there's no solid guidance. I believe there's permissive guidance of when to screen, and that permissive guidance comes from the ADA for what kind of patient or family right now.
The ADA does say that you need to screen. These are the antibodies to screen, and they identify certain groups that are at higher risk than the general population. And obviously, these are individuals that have a relative with type 1 diabetes, but also individuals that have or have somebody in their family with an autoimmune condition. Low thyroid levels or overactive thyroid levels are two good examples. Celiac disease, gluten intolerance, which also is an autoimmune condition. Because when you have an autoimmune condition, you're more likely to have a second one. And both type 1 diabetes and thyroid disease and celiac disease and a number of other autoimmune conditions are all in that basket. And so that's the recommendation for right now is you have a family history of type 1 diabetes, or you have somebody in your family, or you yourself have an autoimmune condition, might be a good idea to get some autoantibodies to type 1 diabetes. What we want to eventually get is to general population screening and obviously starting with children. And there's some interesting things that we can do. There's a lot of research that's going into identifying certain genetic markers that put you at a higher risk category for developing autoimmunity. And that work is going on and hopefully will help inform how we might go to general population screening in pediatrics.
I think I'm a little bit more aggressive than the recommendations are and that where you're at right now. I think we should be testing all the kids at 2 and 4 years of age. And I particularly urge people in rural America to be very aggressive. And the reason I say that is because we already know that's a risk factor. A lot of our children in rural America live in poverty. But also, if you live in Maui, Hawaii, which we don't tend to think of an underserved area, they don't have on the island a pediatric endocrinologist. They don't have a pediatric emergency room. They don't have a pediatric intensive care unit. If a child presents in DKA, they can minimally stabilize them in the ER and then wait for a plane to fly in 20 minutes to get to a children's hospital. If you're in Winfield, Kansas, and you're one pediatrician at a critical care access hospital, at a 20-bed hospital, a child with DKA is a disaster. And you have to wait 3 hours for a plane to come down from Kansas City to pick them up. So if you're prepared and you know that they're positive for the autoantibodies, you may be able to 90% of the time avoid having to face that. And to me, even if I just can avoid it twice in my lifetime, in my career, it's worth the effort. It is worth the effort not to be in that stressful situation with the patient. So I'm a little bit more forward leaning than you guys are at this point. I think, especially in rural America. where access is
We
not so
need
high.
more people like you leading the charge, or
We need to
that
push
sure
hard.
makes a difference.
They don't make a huge difference. No, the phenotype of type 1 diabetes has also changed as our bodies have changed in rich countries. So
Mhm.
we used to think about the skinny child as the one with T1D. How's that not true?
Yes, we used to think of the skinny child as the one with type 1 diabetes, but unfortunately, we have an issue with overweight and obesity in, for example, the U.S. So 30% of our children, of our adolescents are obese. The statistic better than I do, but being obese does not protect you from getting type 1 diabetes. And therefore, the kids that get type 1 diabetes, about 30% of them will be in the obese category. What complicates matters is that now 1 out of 5 children that present with diabetes will have type 2 diabetes. And so we also need to differentiate between, is this child have type 1 or type 2 diabetes? And my recommendation would be any child that presents with diabetes will need to have autoantibodies just to understand, is this type 2 or is this type 1 in a child that's overweight? Obese?
And I'm pushing the envelope. But if I have a 10 or a 12-year-old with a hemoglobin A1C of 5.7, 5.9, pre-diabetic range,
Mm.
why would I wait till it's 6.5 to get the autoantibodies and figure out, is this a stage 2 type 1 diabetes with obesity, or is this an obese patient with metabolic disease? And why would I wait till they're actually diabetics to start intervening?
It's a great point, and I think I agree with you. In children with abnormal glucose parameters, I would have a very low threshold for checking autoantibodies. And it also brings up the question as to what other parameters might you look at to identify somebody who might be at risk. But yeah, Herb, that's a great point. If you have a child with prediabetes, darn, I would check an autoantibody to make sure they're not autoimmune.
Yeah, but I'm a little forward.
So that's great thinking.
And then there's a very interesting term, insulin resistance.
Mm.
What is insulin resistance?
Yeah, and insulin resistance is the body not using insulin effectively. And what do we mean by that? One of the main functions of insulin is getting glucose from the circulation into cells, right? Into muscle cells, into the liver, into fat cells. So it can be metabolized and either be used or stored for energy. If you don't have enough insulin, that doesn't happen. But in individuals who have insulin resistance, they may have plenty of insulin production, but that insulin isn't very effective at getting glucose from the circulation into the cells. Think of it as, instead of opening 10 doors, it just opens one door, and so only one glucose molecule can get through. So what the body does for many years in those and anyone is it just makes a lot of insulin. If I were to test blood sugars in somebody who was going to develop type 2 diabetes but hadn't done it yet and was insulin resistant, my insulin levels would be very high. What happens over time, though, in some of them, there's a genetic predisposition that insulin production can't keep up with the resistance, with the need, the body's need, and eventually it falls to a point where blood sugars start coming up. And insulin resistance is very common, right? When you have weight, especially around the waist, right? That's metabolic reactive weight.
And interestingly enough, hyperglycemia is toxic to the pancreas.
Hyperglycemia, yes, there is a term, right? I think you're referring to glucotoxicity or even lipotoxicity. Yes, with very high glucose levels, there is a stunning of the beta cells. And in some cases, as you bring down the blood sugars, those beta cells will recover some function. It takes some time, it takes 3-4 weeks. Those beta cells will recover at least some function from being stunned by high blood sugar levels or even high lipid levels, high fatty acids.
And so then again, this is all I got to clear out so many biases of myself here. I thought insulin resistance only happened in the obese population, but there is insulin resistance in the non-obese population.
There is a lot less common. It's insulin resistance. You think of in terms of, yes, the individual that's overweight or obese, but not any individual that's overweight or obese. You've heard of weight that accumulates around the waist. That type of fat also accumulates around organs. And that's the type of fat accumulation that causes insulin resistance. There's also weight accumulation that is mostly subcutaneous, right? It's around the hips, the legs, the arms, but not so much around the waist. And that type of weight actually does not cause as much, or if any, insulin resistance. So that's that. But there are certain conditions that give you insulin resistance. So women who have polycystic ovary syndrome have insulin resistance. Their insulin levels are higher than women that don't have that. And there are certain genetic conditions that also can cause insulin resistance. And there's a group of conditions called lipodystrophies, where there's a maldistribution of fat in the body that can also be associated with, in that case, severe insulin resistance. There are genetic factors that can drive insulin resistance, and then there are weight factors, as you point out, that can drive insulin resistance.
And so when I look at this now from a more holistic approach in what we have learned over the last 30 years, thanks to people like you, it feels like type 2 diabetes is a late complication of a certain type of obesity. That central obesity that causes metabolic sickening of your body. And there's many factors involved. One is the insulin resistance. Two is the exhaustion of the pancreas. And three is the inflammation and toxicity that are produced by those fat cells around your gut and your liver and your middle gut organs. And so, from a pediatrician's point of view, what I want to do is prevent obesity before I have to treat diabetes. Is that the understanding now of the science?
I think so. There's a lot more that we need to understand, but you brought out a point that was not quite understood when I got out of medical school, is that the environment that surrounds insulin resistance is an inflammatory environment. And you can actually measure some evidence of inflammation. And that combination of inflammatory environment, elevated insulin levels, elevated blood sugar levels, elevated lipid levels, all combine to drive what you were calling metabolic syndrome. And this metabolic syndrome is obviously associated with an increased risk of high blood pressure, an increased risk of heart disease and cancers, and a lot of other chronic conditions, including obviously type 2 diabetes.
Yeah. Unfortunately, and I've shared with you a couple of cases, this disease process had been slowly creeping into the adolescent, which is a shame of in itself. But now in clinic, I'm seeing 10 and 11-year-olds with full-blown metabolic syndrome, obese, central obesity, abnormal lipids, hypertension, pre-diabetics. And it's extremely frustrating because I don't have the data to know if I can take 15 years to correct this problem. I mean, maybe it doesn't make a difference. I don't need to touch it. And they'll be happy and they'll need treatment when they're 30. Or maybe those 20 years of inflammation and exhaustion of the pancreas will have a horrible, non-reversible damage. And we don't know. We don't know how aggressive to be. And the other hand, we don't know what the side effects of the interventions are when you're on these medications for 20, 30 years, starting at 12.
There's a huge concern, right? Kids that develop type 2 diabetes at an early age. It takes 15, 20 years to develop complications. means that if you develop it at 15 years of age, by 30 to 40 years of age, you're now experiencing complications that usually a 60 to 70-year-old person with type 2 diabetes is experiencing. And that is huge, let alone the cancer risk. What we're seeing, I think, were you the one who was telling me that you're seeing more cancer in kids these days? Certainly seeing it in young adults.
Yeah.
And sure, there's got to be environmental pollutants out there, and we're almost made of plastic by now, but you've got to also think that could some of this metabolic syndrome and insulin resistance and inflammation be driving some of the cancer incidents that we are seeing in younger groups of people?
I do think that cancer most likely is also related to this metabolic disease. Also, I think that maternal mortality is affected. And we do know that women that suffer from, what do we call it, insulin during their pregnancies, the children are affected by that
Mhm.
state. Now, there's another condition that I became aware when I was talking to you about in Andrea and Nicholas. And it's some children already have both type 1 and type 2 diabetes. That's mind-numbing to me. How can you have both?
It's yes, that's a confusing thing, right? Because diabetes means that your beta cell isn't making enough insulin to keep your sugars controlled. And type 1, you get there because your body, your immune system attacks your beta cells. Type 2, you get there because your beta cells get exhausted. And there's probably other predisposing factors that we still need to find out. But the end result is hyperglycemia. But if you have type 1 diabetes, you have autoimmunity, and you have metabolic syndrome, then you basically have both the features of loss of insulin production because of your autoimmunity and insulin resistance because of your metabolic status. And that's often referred to as combined type 1 and type 2 diabetes. Maybe a better way of describing it is you have type 1 diabetes with insulin resistance, but sometimes describing you have a combination of type 1 and type 2 diabetes may resonate more for certain people.
That must be a very difficult disease to manage.
Yes, absolutely. It is, yes, because you're managing the complete insulin deficiency in type 1 diabetes with the increased need of insulin to drive blood sugars in. On top of which, with metabolic syndrome, you tend to also have blood sugars that are higher, lipid levels that are triglycerides that are high, good cholesterol, HDL, and so it's a difficult condition to manage.
Well, what haven't I what have I not asked you?
We've talked about a lot of different things. You haven't asked me what place are we going to go eat next time you come down to Miami. But
I thought we were gonna go to Italy and eat it.
oh, Italy, there you go. I got a colleague, Francie Morales, that does some great places in Miami that she's identified. I'll have to figure it out. But no, but this has been really a wonderful conversation and a much needed conversation because
Thank you.
type 1 diabetes is we're just scratching the surface, but understanding and identifying the autoimmunity as a first step and then understanding the metabolic status and staging, so important. And I'm really grateful to both of you for having this conversation and asking me to join your wonderful podcast. And first episode in 3 years, man, I should have had the banner up here.
Thank you so much. I admire you tremendously for the work you've done. You're a phenomenal leader. You're what I call a quiet genius, which is all these physicians that are quietly moving the needle day in and day out. Some work for pharma, some work at the hospital, some work like George in a big practice, some work in a little clinic. And every day we're trying to push the envelope a little bit towards the cure of one or another disease and the healing of our brothers and sisters, our patients. And I want to close out not only thanking you for all this work that you have done for your friendship, but again, reminding the audience that there is tremendous amount of hope, tremendous things being done. And I know I'm being a little bit Pollyannish, but the cure is right around the corner as we understand these concepts. And maybe before we're retired, we will see a cure for this disease.
My sister would kiss you. I've been waiting for a long time. So let's just keep it alive, keep driving. And as you said, it takes a village to address this disease. So thank you for being the village.
Thank you. Have a wonderful afternoon.